Dr. Lesego Mawela. He is an executive director at DMHS, which is the Dr. Mawela Health Solutions. And Dr. Mawela is a medical doctor, entrepreneur, and facilitator for over 16 years. He has completed postgraduate diplomas in HIV medicines and tropical medicine. He is a founder of Dr. Mawela Health Solutions, a healthcare entrepreneurship firm that has birthed AquaH Training School, Clinic Telehealth, Clinical Care Platform, and Mbombela's Women's Clinic, and AquaH Primary Health Care Clinics. He is a member of the National HIV Guidelines Committee, an ex-board member of the SA HIV Clinician Society, and a lead consultant for national HIV quality improvement strategies for achieving the UNAIDS 1990 strategy. His passion in life is to inspire hope and wellness by enabling health providers to do remarkable things and lead fulfilled lives. For more information, you can visit his website, www.drmawela.com.
There we go. Thank you very much. Thank you very much for this opportunity. My appreciation goes to the Foundation for Professional Development for making this meeting a success, but also yourself, Wenzel, for the nice introduction. I have a very dark skin color, so I can't blush, I can only become gray. But I really appreciate that introduction. I must also appreciate Dr. Chris, who wrote to me and say he wants to give me an opportunity to share my knowledge around HIV and AIDS, and importantly, to appreciate the audience for making time. I know health workers are quite busy people, so it's an honor for health workers to take their time just to come and spend with us an hour or two to talk about HIV in pregnancy. Just to say that this particular topic is of interest to me because I spend a lot of time on the program side of the PMTCT program, and I hope that we will be able to share some insights. It's going to be an engaging session, so I also look forward, to you engaging with me, sharing your comments, but also some of the poll questions where I would be asking you. I know some of the questions are going to be very, very basic, but I hope that that will really enhance engagement and learning. So I'm going to start from here and to say that for today, in terms of this particular topic, it's not more around the science and really scientific evidence around PMTCT. I think we have enough of science around HIV. The gaps we have really are around the implementation of the guidelines as they are written. So I'm more going to focus on the practical approach to implementing HIV management guidelines as it relates to pregnancy, and then zoom in there and there, looking at issues of the viral load and how do you approach women who might be failing ART at that point in time. So just to start and kick off this session, we have a 34-year-old Maria who presents to you, and this is her first visit. That means she's presenting, she's pregnant, she's coming to you for the first time. As you examine her, you estimate that she should be around 5 weeks pregnant. She expresses some interest in HIV counseling and testing, and you offer her, the counseling and the testing. And I just have the first question already for you. I don't know if Monica and the team are here just to share the first question with you. So her HIV rapid screening test is positive. What do you think are some of the things that we need to do following this particular test? Yes. Should I share from my side? All right, I will do that.
We have shared, Dr. Lesego.
Oh, thank you. Yes, I can see. Thank you. Okay. All right, let's give it a try. What happens if someone else's rapid screening test? I think on this one, we could have allowed multi-choice, but it's fine. We will just discuss with you. 2 more seconds. If we can all participate, it would make it an interesting discussion. Okay, thanks. Let's look at the results. So yeah, so those are the results. I hope you can see them, that about 25% said that we must provide post-test counseling. A small percentage said, let's start her on ART. A big number, which I'm in agreement with, we need to do a confirmatory HIV test. And then some people believe that we should do baseline assessments at that point in time. So yeah, I think what is very important at this point, this HIV testing is very important because it is the entry point into the HIV program, particularly in terms of treatment. For the PMTCT program, it's also equally an entry point that must be emphasized. And luckily across the country, most health facilities are able to achieve testing rates in excess of 95, 98, some facilities even 100%. If you find that you have a low uptake of HIV testing in your institution, you probably need to look at the quality of counseling that is being provided and start to work on processes to improve your uptake. So this is just to remind us that sometimes pregnant women suffer, based on the entry point. Remember, some women would present pregnant and then they are seen by a midwife who then is supposed to offer HIV testing, right? But half the time you'll find that some midwives are not necessarily NIMR trained. And because of their midwives, they are likely to focus more on the traditional, pregnancy care packages rather than to look at these women holistically. So, and there's the other entry point, which is the HIV side, where a woman comes in, she tests positive, and as you collect the urine to check, whether she's pregnant or not, you find that she's pregnant. But in this instance, she's then seen by a NIMR trained or an HIV trained health worker, who most of the time tends to focus more on HIV, right? And neglect, sometimes some of the pregnancy assessments and treatments that need to be offered once a woman falls pregnant. So in the PMTCT program, it's very important that we see this woman as someone who needs to receive integrated care, irrespective of where she is assessed, So we need to make sure that she receives her basic antenatal care package of services. We need to ensure that she is tested for HIV. If she's positive, she's offered ARVs. We need to ensure equally that STIs are screened, TB is screened, and effective treatment is initiated, as timely as possible. So it's very important to note that whilst the question there is about HIV testing and the fact that the screening test is positive, we should not miss the fact that she is pregnant, and all pregnant women, as soon as the pregnancy is diagnosed, are supposed to receive basic antenatal care as a package of services without turning her back, without really saying, in this clinic, we see pregnant women on Thursdays, therefore come next week. It is actually relatively illegal in this country to turn a pregnant mom away. If she tests positive today, she should then be offered basic antenatal care services same day. And where we identify that this is a high risk pregnancy, we should then consider referring her at the higher level as required. So this is very important. So when we talk about this basic antenatal care services, HIV testing is just one component of it. In this instance, we have offered her the screening test. We have not yet confirmed that she is HIV positive. So it's quite important that we look at it that way. So during the first ANC booking, like in our instance, the case of Maria, she's presenting for the first time pregnant, we must offer HIV testing. If the test comes back negative, we want to retest, offer her the test again at every subsequent visit as per the pregnancy antenatal schedule. And if the test is positive, we don't want to rush to give her ARVs. We want to confirm whether this is truly a positive result, and then also offer post-test counseling. This is just really an algorithm based on the HTS guidelines from 2015, where we say when women come in for care, we have to provide an information session. This group session is very important because it encourages women to be willing to test, right? And if they are given information when they come to a consultation room, is just to verify the level of information they know, clarify any issues they have. And if she agrees to test, we would then test her. In our case scenario, we are just on that particular block there. She has just tested positive, and we have not yet confirmed with a second test that she is positive. As a rule, we should never find ourselves diagnosing HIV with one test, right? Whenever we diagnose HIV, you always need two tests, two positive tests, whether it's rapid tests, whether they are doing a rapid test and an ELISA, whether it's a PCR test confirmed with another PCR, but we always diagnose our patients with two tests. So this is where really we are with our case. If she had tested negative, we will be providing her with regular testing in subsequent visits. If she refuses to test, we don't stop there. We provide post-refusal counseling, bring on board another health worker to try. If she is still not interested in the subsequent visits, we can then offer her that particular test, right? So that is very important. So in terms of our same case, a confirmatory test is then done, which also comes back positive. If you remember, we did a screening test which was positive. We have now confirmed that she does have HIV because we have two tests that are done. What do you think should be done at this point in time? Now that we have confirmed the HIV status, what do you think should be done? Can we move to question 2? Yes, thank you. So if you look at the first option there, post-test counseling, very important. We have to offer post-test counseling. And for pregnant women, this is very important. Sometimes, women come in because they're nauseous and we tell them that, oh, by the way, you are pregnant, and they were not expecting to be pregnant. And whilst they're still coping with that, we offer them HIV testing. It is now positive. Now we are telling them, look, your status is positive. And whilst they're still trying to cope with this positive test, we are now telling them that if you're not careful, your child might be born with this disease, which is incurable, but we could have prevented it. I guess they have to go and disclose to their sexual partner. So usually it's too much for women, to take in one day. So this post-test counseling, we should not see it as an event, right? This should be an ongoing counseling where we give bits and bits, and at every subsequent visit, we try to empower women and give them more and more information. Same-day ART initiation is encouraged in pregnancy because we believe that a high viral load in pregnancy is a medical emergency. So we want to ensure that we start women on ARVs, as soon as possible. Basic antenatal care, baseline tests. The only point in this assessment, which we are not agreeing with, is to start ARVs after 7 days, because we want to start most women same day. Where a pregnant mom has tested positive and she's clinically unstable, that's when we might want to treat opportunistic infections and maybe delay by a week or so. But really 98, 99% of the time for clinically stable patients who are willing to be started on ARVs same day, we should be starting them on the same day. So that is quite important at that point in time. So these are some of the services we have to provide. So firstly, it's basic antenatal care, a full exam assessing the previous obstetric history, complications, medical conditions, and then providing also some of the baseline tests that are linked to the basic antenatal care, your RPR, your HB, urine dipsticks, checking the blood pressure, blood sugar. So the whole basic antenatal care must be provided to a woman irrespective of the entry point. From the HIV side, quite important is that we need to offer prophylaxis therapies, and we've got Quadrimoxazole, isoniazid, and fluconazole prophylaxis therapies, which are very key, and we will discuss these shortly. We have to do your baseline CD4 count, stage the woman, screen for opportunistic infections, and treat, But sometimes we miss this particular pillar, psychosocial aspects of testing for HIV for the first time when you are pregnant. Women are so worried. They have so many concerns. And we also do not have enough time, to talk to them at that point in time. So this is very important that as we want to prepare and start women on ARV, that they should be psychologically ready, but also we must address and assess the psychosocial aspects, access to food, issues of literacy, issues of gender-based violence, and whatever is important for that woman on that particular day becomes very important. In terms of some of the assessments, if you look at the consolidated guidelines, we have to make sure that we weigh our women, you do your BMI, you do your MOAX, we screen for TB and other opportunistic infections. WHO staging is very crucial because it tells us, how immunocompromised, is our patient. The viral load schedule is a bit different, and we will discuss that very shortly. The CD4 count must also be done at CD4 count. Appropriate prophylaxis must be initiated based on the level of the CD4 count. We must educate women about side effects and also advise them how to deal with side effects should they experience them. So the overall comprehensive assessment of women who are pregnant when they test positive is quite important also in the PMTCT program. I know these are called basic assessments, but it's interesting how as the years go by, we lose health workers who are experienced in this field. So we must stage women. Generally, when we say someone is WHO stage 1, we are referring to a patient who is asymptomatic. They might have some lymph nodes there and there. Stage 2, mostly limited to skin conditions, herpes zoster shingles, herpes simplex on the mouth, ringworms, stage 2 conditions. Stage 3, things are getting a bit worse, where patients are losing significant weight, diarrhea for more than 1 month, pulmonary TB, very important, a significant contributor to maternal deaths, in the country. So we are still going to discuss this a bit. And when we get to stage 4, we're talking about AIDS defining conditions, particularly extrapulmonary TB, PJP pneumonia, which is preventable, cryptococcus meningitis, which is also preventable. This month it's cancer month, invasive cancer of the cervix, hence our need to screen women and do pap smears. So it's important that when pregnant women test positive, we also offer them a chance and assess them in terms of the staging, and then we take it from there. Right. In terms of timing for starting ARVs, we want to fast track to same-day ART initiation for most women, as long as clinically she's stable, but also psychologically, she's willing, because there's no point in really initiating people on ARVs when they are not psychologically ready, because the end outcome is the high defaulter rate that we are seeing after ART initiation. Where it's a significantly immunocompromised pregnant mom, you might want to delay for 7 days as you investigate and treat opportunistic infections. If she's got TB, we generally prefer to start ARVs 2 weeks after TB treatment has been started. However, in the PMTCT guidelines, you would see that even when TB is diagnosed, we still want to push to same-day ART initiation for stable pregnant moms. However, if she's unstable, she's hypotensive, she's tachypnic, she's tachycardic with very high pulse and respiratory rates, you might want to delay the start of ARVs and treat TB first for 2 weeks, then start ARVs later on. Patients who have TB meningitis or cryptococcal meningitis, these are very bad infections. We always prefer to treat these infections for at least a month. And once your patient is clinically stable, you may then start them on ARVs. But by all means, most of our women present when they are still healthy, when they are still well, and we should be able to initiate them on ARVs same day for the majority. These are some of the ARV drug classes and options we have. You've got your reverse transcriptase inhibitors. The commonly used one would be tenofovir. Where tenofovir cannot be used, we usually opt for abacavir and zidovudine being preferred as part of our second-line ART regimen. Lamivudine, emtricitabine, always in the regimen, a choice between the two. These two can be used interchangeably, right? Please note that tenofovir can only be used if the creatinine clearance is above 50. For non-pregnant adults in pregnancy, we use a creatinine level. As long as if it's above 85, below 85, it's acceptable. And if the weight is below 35 kgs, we want to avoid the use of tenofovir. You've got your non-nucleosides, and generally we want to reduce the use of this particular class of drugs because of their low barrier to resistance, leading to patients needing to be switched to second line, very early in their treatment. So we don't want to be starting women on efavirenz unless if we have absolute contraindications to our preferred drug, which is dolutegravir, which is given as a 50 milligrams daily per hour dose. And you will see now it is now recommended for all women, irrespective of fertility plans or pregnancy duration, right? So if you've got a treatment naive, a newly diagnosed HIV positive pregnant mom, the preferred regimen would have tenofovir in combination with lamivudine, and the third drug being dolutegravir right there, right? The only time you would opt to use a drug like efavirenz is where you have absolute contraindications to dolutegravir, and the common context, it's a drug-drug interactions where dolutegravir should be avoided. Your protease inhibitors, generally, we keep these particular drugs as part of our as part of our second line and third line ART regimens. So if a patient has absolute contraindications to dolutegravir, or they have failed a dolutegravir-based regimen, lopinavir, ritonavir becomes an option for those particular patients. All right, and this is how you use the drugs. So if you note the NRTIs are these 5 particular drugs. At the principal level, your ART regimen should always include 3 drugs, 2 NRTIs, and a choice between an integrase inhibitor or a non-nucleoside or a protease inhibitor. If you look at our standard first-line regimen in pregnancy, TLD would be a combination of tenofovir, with lamivudine and dolutegravir. So this is a 3-drug regimen where there's contraindications to tenofovir, maybe renal impairment. We would then opt to use abacavir, lamivudine, and dolutegravir. Where dolutegravir cannot be used, we would usually opt for efavirenz, and then later on maybe lopinavir, ritonavir. So this is kind of like a principal table to say you should always have 3 drugs, 2 nucleosides plus a choice between these 3, and we always switch, downwards. We don't want to be going from tenofovir to zidovudine. We want to keep this drug for second line, but where we are pushed, where both these particular drugs cannot be used, then we might have a patient taking zidovudine as part of a first line regimen, right? Now, I know there's been a change to say, because now we have science, and science has confirmed that there is no significant difference in neural tube defects when you compare dolutegravir and efavirenz. The key thing here is that, yes, DTG is now recommended to be used for women who are pregnant and not pregnant in all trimesters, but we should not let go of the good things that we were doing in the last few months or years. We were starting to push towards an integrated approach in terms of sexual reproductive health services. So even now, though both drugs are regarded as having the same safety risks, it's always important to talk to women whenever you initiate them on ARVs to understand, currently if they are pregnant and if they have plans to fall pregnant in the future, because that helps you to also have a discussion around the need to delay and why they need to be optimized health-wise before they fall pregnant. So these discussions are still very important. And a discussion to say, by the way, DTG and efavirenz are now regarded as having the same safety profile in pregnancy. However, dolutegravir would always be preferred over efavirenz because it has a better side effect profile. It's quite potent. The time it takes to suppression is quite, faster, but importantly, no drug interactions with contraception. So it becomes a preferred ART drug of choice, particularly for women who are still planning to not fall pregnant or to fall pregnant. That's not the point. And then the issue of discussing family planning, we must remember when we discuss PMTCT at a public health level, PMTCT does not start with HIV testing. It starts with the first pillar, which is ensuring that women who are HIV negative stay negative. So prevention efforts being important. And then the second component is to increase access to family planning, because we want to eliminate unplanned pregnancies contributing to a high number of babies who might be born at risk of having an incurable but preventable disease. So DTG is now fully recommended for women of childbearing potential, but also those who are pregnant, whether in the first, second, or third trimester. In deciding whether to offer dolutegravir or efavirenz, the whole discussion around neural tube defects it no longer carries weight, because the two drugs have a similar risk, right? However, you'll see that the dolutegravir remains preferred because it is potent, it is easy to take, it has a high barrier to resistance, and no drug interaction with hormonal contraceptives. This is huge. I remember I saw Dr. Ongole on the group. He might remember the case as part of the pharmacovigilance bulletin, where we had a young woman who had an implant on, and she presented with an ectopic pregnancy, and it was not picked up that how do you get pregnant when you have an implant? And then she came back 3-4 months later for a second ectopic pregnancy. Can you imagine losing both tubes whilst you have an implant, because the implant had failed because of drug interactions with ARVs. So sometimes we don't appreciate what this particular sentence carries, you know, for women who might fall pregnant whilst on family planning. And I think an unplanned, all babies, you know, are a blessing. We love them, but we prefer them when we are in control and we can time when is the best time for us to really fall pregnant. In pregnancy, we encourage the use of fixed dose combinations. So in your prescribing habits, it's easy when it's TLD, right? But sometimes when you have to switch to second line or third line, or when there's a drug-drug interaction and you have to interrupt the fixed dose combinations, always pay attention to some of the available fixed dose combinations with an aim to reduce the pill count, because pregnant women also take other tablets because of, you know, basic antenatal care services. So we want to reduce the overall pill burden for our patients at that point in time. So these are some of the prophylaxis therapies, because we are still talking about the assessment and the initiation process and some of the key things we need to offer to women when they're pregnant. In terms of Quadrimoxazole, most pregnant patients are adults, but as you have seen, after COVID and the implications of COVID on sexual reproductive health services, we have a lot of teenage pregnancies, including young adolescent pregnant young girls, 10 years, 11 years, whom are generally the children, you know. But all in all, most pregnant patients are regarded as adults and would be eligible for Quadrimoxazole if their CD4 count is less than 200, or they are clinically WHO stage 2, stage 3, stage 4. I think a critical change in the guideline is when to stop. Previously, we used to say stop Quadrimoxazole when you have 2 CD4 counts above 200 6 months apart. Now, with the new guidelines, you only need one reading, 1 CD4 count above 200, then you should be able to make a decision without consideration for staging. Though in my own clinical practice, I always look, you know, if I have a very sick patient with a high CD4 count, I would still keep them on Quadrimoxazole at that point in time. In terms of TB screening, just remember that for non-pregnant adults, right, we rely on TB screening, symptom screening as an entry point, right? If someone is asymptomatic and there are no contraindications, no alcohol abuse, no previous allergy, you know, to INH, no pre-existing liver disease, we would then initiate them. However, in pregnancy, women would need to meet 3 criteria. Number 1 is that we screen all pregnant women for TB, irrespective of TB symptoms. We would then do a TB gene expert, right? It's very important to know that this test is part of basic antenatal care tests that must be done for all HIV positive pregnant moms, regardless of whether the symptom screening comes back as symptomatic or asymptomatic. A TB expert test must be done. And then also we do a CD4 count. And if the CD4 count comes back and it's higher than 350, we would then avoid TB preventative treatment or INH. In this instance, those women would then be reconsidered for TB preventative treatments during the 6 weeks visit post natal after delivery, right? So, and really the reason is the issuing of INH in pregnancy is associated with bad obstetric outcomes, intrauterine growth retardation, sometimes premature deliveries, you know, and so on. However, when you look now to the women who are at risk, particularly those with CD4 counts less than 350, the benefit of giving INH outweighs the risk of bad obstetric outcomes, right? So it's important that for the high risk women, HIV positive women with a negative TB screening, a negative gene expert, but a CD4 count less than 350, we should be offering TB preventative treatment for this particular group of women. And it's the same schedule as non-pregnant adults, 300 milligrams daily for 12 months, together with pyridoxine, 25 milligrams daily. All right. Note in terms of fluconazole that we have a new algorithm, right? This is an old algorithm because once you have a positive CREG antigen, we would make a decision based on whether a patient has symptoms or not. So this has expired. We no longer follow this particular algorithm, but this is the updated algorithm, which is in the consolidated guidelines, right? So basically, if you have a woman who tests HIV positive and a CD4 count is done, which comes back as less than 100, the lab will do a reflex CREG antigen. Now the CREG antigen comes back either positive or negative. If it comes back negative, we don't have issues there. Probably should have already been on ARVs. You just continue from there. However, if the CREG antigen, serum CREG antigen, the antigen from the blood comes back positive, we would then need to do a lumbar puncture. This is the first change in this algorithm. Remember, the old algorithm would have said, is she symptomatic or not symptomatic? Now we no longer rely on symptoms, right? We have to do a lumbar puncture. In other words, all patients who have a positive serum CREG antigen must receive a lumbar puncture. If the lumbar puncture is positive, so the serum CREG is positive, the CSF CREG is positive, this patient has a meningitis and they need to be admitted and be treated as a meningitis for at least 2 weeks in a hospital, all right? However, if the serum antigen was positive, however negative in the CSF, so we have excluded a meningitis, we can then provide the fluconazole prophylaxis therapy, which is fluconazole 1,200 milligrams daily for 2 weeks. After these 2 weeks, we then shift to the consolidated phase where we reduce this 1,200 to 800 milligrams for 2 months. After 2 months, we then reduce it to fluconazole 200 milligrams daily for at least a year, right? Our patients should not receive less than 12 months of fluconazole. And after 12 months, you can only stop if the CD4 count is above 200 and the viral load is suppressed. The patient must meet both 3 criteria, which is they must have taken it for a year, the CD4 count must be high, and the viral load must be suppressed. This group of patients on this wing, we will start them on ARVs after 2 weeks of antifungal therapy. So as soon as they complete the 1,200 milligram, as we start the consolidated phase, we can then start them on ARVs. Also note that it's important that the LP here, the need to do a lumbar puncture should not delay the starting of fluconazole. So where a lumbar puncture cannot be done same day, for whatever reason, it's a rural hospital or there's issues, we are allowed to start the fluconazole whilst awaiting your LP results, and then we take it from there based on the results. So I hope you are following me. If there's any questions, I will see them in the chat or in the Q&A towards the end. Let's continue again with Maria. So Maria, remember, we tested her, we confirmed that she is positive. Our preferred regimen would have been TLD, tenofovir, lamivudine, and dolutegravir. However, she was started on tenofovir, lamivudine, and efavirenz, right? And then her baseline CD4 count is 250. She's got a creatinine of 90, which is above 85. Remember, don't forget that, which is above 85. And then she's got a gene expert, TB expert test, which is negative, right? You are seeing her now, she's been initiated, she's been on ARVs for 3 months. So you are seeing her for her 3 months follow-up. She has no complaints. She was, however, started on TB treatment 1 month ago. So it means now she's taking this particular regimen. She's 1 month on TB treatment. This is now 3 months on ARVs. She's, however, a good patient, good adherence, and has never missed any appointments so far. So there's question 3 there. When patients present to us for a 3 months follow-up visit and they are pregnant, what assessments need to be done during a 3 months post-ART initiation visit? What assessments need to be done? Can you help me there? Yeah. Yeah, this one you can select more than one. I'm happy with that because it helps you not to be limited. If you have, if you think more than one of these must be done. All right, 2 more seconds. Great stuff. All right, I'm going to pause. I know you're supposed to help me that side. I'm sorry about that. All right. So creatinine at 3 months, yes. Remember, once you start a patient on tenofovir, you must do a creatinine test. Then you've got your viral load. Yes, if she was non-pregnant, you wouldn't choose a viral load. But because she is pregnant, a viral load must be done when she is 3 months on ARVs, particularly for all newly diagnosed, newly initiated on ARVs during the current pregnancy. At 3 months, we must do a viral load. Basic antenatal care, yes, but a CD4 count, no. I see 25% of you said we will do a CD4 count. So we are not going to do a CD4 count. Remember, a CD4 count is done at baseline and then again when she is 12 months on ARVs. So we do have a baseline CD4 count, which is 250. Basic antenatal care, yes, we want to assess a pregnancy fully. A viral load, yes, it is due. And then a creatinine, yes, it is due, especially because the previous one was 90 and she's still taking tenofovir. Ideally, if the creatinine is above 85, you want to avoid the use of tenofovir in pregnancy. And in addition to that, a creatinine above 85 reclassifies the pregnancy as a high-risk pregnancy, right? We don't want women who are pregnant who've got renal impairment because that complicates the whole pregnancy right there. So don't forget to provide comprehensive antenatal care. I just used the schedule for non-pregnant people because I wanted to show you things that must be done at 3 months beside the viral load. So we have to talk to her about side effects, screen her for TB, and she has TB in this instance, assess adherence, encourage safer sex, check her sexual partners, bring them on board for testing, including children, assess a pregnancy weight, stage her every visit. Pregnant women must be staged every visit because you want to see whether there's clinical progression. Remember, she was asymptomatic when we started. Now she has TB. Probably she has progressed. The first viral load in pregnancy is done at 3 months. So we don't follow the non-pregnant schedule. And then these other tests are only done if the patient is taking a particular drug. So we wouldn't do an HB, right, if she's not taking zidovudine. However, for pregnancy and for basic antenatal care, we might do an HB if it's indicated. We will do a creatinine at 3 months, and then if she was taking lopinavir, ritonavir, we would do, a cholesterol test there, which I think it's not indicated in our scenario. So here's the viral load monitoring approach for pregnant women. So if she tests positive, she's newly diagnosed and initiated during the current pregnancy for the first time. We start her on ARVs, and the first viral load will be done at 3 months when she's 3 months on ART. If it comes back suppressed, the next viral load will be done at delivery. Then if that delivery viral load is suppressed, we then repeat it every 6 months during breastfeeding, during the postnatal phase. if you have a woman who is known positive on ART and she falls pregnant whilst taking ARVs, right? During that day when you are diagnosing the pregnancy, you are going to do a viral load. If that viral load is suppressed this is a baseline viral load, right? During the pregnancy diagnosis. If it is suppressed, we do the next one at delivery. If it is suppressed, we repeat it every 6 months during breastfeeding, right? If there is a known HIV positive woman, so she knows her status, but at the time of pregnancy diagnosis, she's not on ART, but she's exposed. She was previously on some ART regimen, right? You would then start her on a relevant regimen, most likely a DTG-based regimen, then repeat your viral load after 3 months and then act on that viral load based on the results right there, right? So our case, she's newly diagnosed and started on ART during the current pregnancy. So that's why we started her on ART at 3 months. She is due for a viral load, which is key. In the guideline, you'll also find a very nice table like this one for the newly initiated, already on ART, or who presents very late. You'll see our case is this particular column there, where we started her on ARVs for the first time during this visit. At 3 months, she is due for a viral load. And if it's suppressed, we repeat it again at delivery. If it is suppressed, we do it every 6 months during breastfeeding. So this is very important for us to note, right? Now, remember, she's now 1 month on TB treatment, right? So remember that NRTIs, your tenofovir, abacavir, zidovudin, those drugs are generally metabolized through the renal system. And in the context of TB treatment, no dose adjustments are needed. She's not taking DTG. She's on a favorance regimen, which is preferred in the TB context because you don't have to do any adjustments. But if she was initiated on dolutegravir, we would have to increase this dosage from 50 milligrams daily to 50 milligrams 12 hours. So the patient will be taking TLD in the morning and then DTG on its own 50 milligrams at night. Nevirapine, a no-go area with TB treatment. We generally never give nevirapine with TB treatment. If she was taking lopinavir, ritonavir, you would have 2 options, either to double the dose. So from 400 over 100, then we double it to 800 over 200 milligrams BD. Big tablets, right? Almost 4 tablets BD, something like that, right? Otherwise, you can super boost by prescribing additional ritonavir, where we prescribe the standard dose, lopinavir, ritonavir, 400 over 100 milligrams per oz BD, and prescribe additional ritonavir as 300 milligrams BD per oz at this point in time, right? I hope you are still following. It might be a lot to take because I'm covering a lot of issues, but yeah, just remember, as soon as you hear that a patient now has more than 1 medical condition and they are taking 2 different treatments for 2 different medical conditions, you have to always check for drug-drug interactions just to make sure that the drugs for both conditions can be safely be given together without causing a lot of harm for our patient. All right. So the results for Maria, remember, we did a 3 months viral load and a creatinine, right? So the creatinine is normal, so which is good. So we don't have to interfere with tenofovir anymore, except that now the viral load is 10,000 copies per mil. But she tells you, I'm okay, I've been taking my medicine, you know, but she's got a high of 3 months viral load is 10,000 copies. So when you see these results, what is your plan? What do you want to do? Let's go to question 4. What do you want to do? Where's my team there? Okay, I'm gonna do it because I'm not sure.
Monica?
Yes, I hope you can see it. I've just done it from my side. What do you want to do? Interesting. She's got a viral load of 10,000 copies, and she's pregnant. This was done when she was 3 months after starting ARVs, right? All right, I'm gonna give you 2 more seconds. Interesting. There's options that you can never go wrong with, right? You always start with those. I don't know why it says it can't share, but I can tell you that 76%, you said enhanced adherence counseling, and you can never go wrong. I mean, that's something that we must do anyway, whether the viral load is high or not. So that's a tick. Repeat the viral load in 3 months. We're going to discuss that. And that's 27%. And about half of you said repeat the viral load in 1 month. Someone said, let's stop efavirenz and give DTG. Someone says, let's change the regimen to second line. So I think this is going to be, just remember these options as we go through, because I think there's a lot to discuss and to learn. So the first option there was saying do enhance. You can see here, this is what we call a non-suppression viral load algorithm. So how do you approach a pregnant woman who has a high viral load? We use a non-suppression viral load algorithm. It's in the guidelines. Now, remember I said I'm just dealing with application. It's not about science, but how do you apply the guidelines, right? So you'll see the first step, it says if the viral load is more than 50 copies in pregnancy, right, you have to do a thorough assessment. And this is what we call enhanced adherence counseling. And to make it easy, we call it A, B, C, D, E. So you have to talk to Maria, assess if Maria has adherence challenges by checking whether is she experiencing side effects. Does she suffer from any mental health, conditions? Is she able to really, understand the things that you are saying, to take care of herself? This is very important. Is she being abused by substances? Poor social support? Has she disclosed? Because non-disclosure is associated with poor social support. And that means, she might not be having people at home to remind her of her medicines. B, for bugs, does she currently have any new infections? Is she taking the medicines correctly? Is it the correct dose based on her weight? Is she taking other drugs, whether over the counter, under the counter, around the counter, traditional, modern drugs? We want to know so that we can see if maybe there's implications. Remember, she's on TB treatment, but she's taking efavirenz. So we don't expect that to be a significant interaction. You also want to assess whether we should be suspecting resistance, right? And if there's an indication for a resistance test. She's taking an efavirenz-based regimen. Our guidelines do not recommend testing. So as you do your ABCDE assessment, you then create a plan with your patient to say, fine, you are forgetting to take your medicines. Let's then help you with reminders. Let's get someone at home to also, support you, So here we are. She's got a viral load of more than 1,000, which is 10,000. So we are here with our patient, right? It says here, if the baby was born, we would be extending the prophylaxis, right? But the baby is not yet born. However, it is a high risk situation for the baby to be infected. Our plan is then to repeat the viral load in 4 to 6 weeks. So if you remember, there was a point where you were saying repeat the viral load in 3 months or repeat the viral load in 1 month. So the correct answer would have been, we do enhanced adherence counseling. We repeat the viral load in 30 days, in 1 month. That's when we want to repeat the viral load. And we are going to act based on the results of the second viral load. Some of you said, let's switch efavirenz to dolutegravir, right? Remember the principles of ART treatment. You should not change a single drug when you suspect treatment failure. If the viral load is detectable, don't switch a single drug, right? You cannot stop efavirenz and just give DTG when a patient has a viral load that is 10,000. You need to assess your patient and decide if they are failing. Once you have confirmed failure, therefore your patient needs a new regimen, at least 2 new drugs or 2 new classes of drugs in that particular regimen. Some of you said, let's switch to second line. Yay, don't be in a hurry, right? You only have 1 viral load that is more than 1,000. She still has some time maybe to resuppress, and we see how far she's going, we are going to go with her, right? So when you evaluate a patient who has a high viral load, right, it's important that you are a supportive person, you're not very judgmental. We need to have tools to assess adherence in our institutions. We need to do pill counts, and we need to explore with the patient what are the barriers to adherence. Is she forgetting? Is she going through a very difficult time? We need to do a mental health screening. All these things, we do them so that after that, we can then develop some intervention. This is a slide from the ACC training program. And we say, when a viral load is high, there are easy things to do, like plotting the graphs, checking if the dosaging is correct, the timing, if your patient is forgetting, Then there's clinical things like the previous drug history. Maybe we gave her a regimen which she has already failed, especially this one, because she has just started and she has never suppressed. Does she have mental health issues, alcohol abuse, adverse events, other medicines, the sexual partner maybe is already on 3rd line and is failing 3rd line, and maybe we are giving a regimen that won't work. Then there's the difficult things, which is usually the social factors, food security, gender-based violence, staff attitude. So you have to really evaluate these 3 issues in trying to help our case, Maria, at this point in time. We don't like a high viral load in pregnancy. We don't even want to smell it. If you can smell it, your pregnant mom is at risk. Firstly, for her health, a high viral load is associated with a low CD4 count, therefore putting the pregnant mom at the higher risk of very bad opportunistic infections, right? But equally, the risk to the child. You can see there, if the viral load is 10,000, there's a 16 to 20% chance that this child might be infected during this particular pregnancy. And we are saying HIV for this, for our infants, is incurable but preventable. And the only way to prevent it is to always deal with the viral load, as you can see. Even at viral loads that are less than 1,000, as you can see, there is still some risk, for this virus to be transmitted to the little one. So to be honest, we don't want to see a high viral load in pregnancy. We don't want to smell it. A high viral load in pregnancy is an emergency. We want to deal with it as soon as yesterday. In non-pregnant people, we would wait for 3 months before we can decide to switch. In pregnancy, we have 30 days. We give women just 30 days to deal with it. So that is quite crucial, right? So here's the problem now. So we did enhanced adherence counseling. We repeated the viral load after 30 days, but what happened to Maria? Maria disappointed us. She defaulted. She never returned for her second viral load result. Now we are seeing her 4 hours after a home delivery. Can you imagine? What a great concern we have now. So we saw her, we did enhanced adherence. We said we repeat the viral load. She didn't come back. She now has delivered at home. She's still taking that regimen. We are not even sure if she's adherent or not. But in any case, that second viral load, which was done antenatally, was 3,000. So there was some, improvement there, which would have been significant, by the way, because when we compare these 2 viral loads, we compare the logs. Remember, 1 log is a 10th, so it represents a 0 in a way. If you look at 10,000, this would be 4 logs because there's 1, 2, 3, 4 numbers or zeros after the first number, you know, and here is 3 logs. So this would have been a 1 log improvement. It means if we got a chance to evaluate her, we would have still maybe continued a bit and maybe give her the benefit of the doubt that she was going to suppress. But she seems like someone who disappeared on us. So this is now postnatal, 4 hours postnatal. What do you want to do for the mother at this point in time? What do you want to do for the mother? Yeah, let's see. Yes, thanks. You are back. Thank you. This is now for the mother who's now has delivered at home. The last viral load done during pregnancy was 3,000. Today, we don't know what her viral load is. But what do you want to do for the mother, particularly? What's your plan? You may choose more than one answer there. When I give you 5 more seconds, let's all participate. It's anonymous. I won't know. Great. Okay, we're going to stop there. You may stop. Let's share the results. So some of you say continue the regimen. To be honest, I don't know the best thing to do, but some of the things: stop breastfeeding, switch to second line, repeat the viral load, clinical assessment. Yeah, you know. So to be honest, she has put us in a very difficult position, right? But some of these things we can discuss. So it depends on your communication with her. If she tells you that I've been taking my medicines, I had just changed the clinic, I was taking them somewhere, maybe you want to do a delivery viral load because it seems here there was some improvement. If you believe that she's a defaulter, she is high risk, you know, you might consider whether she has failed this particular regimen. So we will do a clinical assessment to check how she's doing. There's no indication to stop breastfeeding at this point in time. Remember, failing first line is not an indication for stopping breastfeeding in terms of our guidelines and the recommendations that are there. Clinical assessment, confirming adherence, and if she's been taking her drugs, repeating the delivery viral load, classifying this pregnancy as a high risk for transmission to the child. On my side, I think that is probably the viable approach. It's not the best approach. I think it's based on what Maria is going to tell us about, you know, her treatment, and also not forgetting that she was on TB treatment. We also want to know whether she completed that TB treatment or what happened from there. But if she's a pure defaulter, she has put us in a high risk situation. Just note that virological failure in pregnancy is defined as persistent viral loads more than 1,000 taken 1 month apart. So if we go back to her, you would have said that she has failed, but there was a 1 log drop between the 2 viral loads. We lost a 0.1. So, you know, there's an element that there might be an improvement of some sort. But in pregnancy, we say 2 consecutive viral loads taken 1 month apart after taking ARVs for at least 3 months. We would then say probably she has failed. And also make sure that once you consider treatment failure, do check the hepatitis B status of your patient, including the HB, especially if we are considering to prescribe zidovudine for our patient. Coming back to our algorithm, this is where we are. The first viral load was more than 10,000. The second one was 3,000. Now 3,000 means that the viral load had dropped by at least 1 log, right? We lost a zero. So from 4 zeros to 3 zeros, right? If you confirm that there is more than 1 log drop, we then need to repeat the viral load in 2 months' time from this point onwards there, right? But in our instance, we didn't get time to discuss this second viral load. So we are repeating a delivery viral load. Yeah, it's not an easy case, but I think we have to decide whether we are switching her to second line or not. I think switching her to second line, if she has opted for breastfeeding, would probably be the best decision, because we don't want the child to be breastfed a very high viral load and putting the poor child at risk. But then let's play a game a bit. I just want to get a sense of how you understand this, right? So here's a patient who presents with a viral load of 433,000. And then the second viral load repeated after 30 days is 9,550 there. So we have moved from 5.64 to 3.9 logs. The question for you is whether you would switch to second line. If you were reviewing these two viral loads, what would be your decision? Because if you go to the algorithm, you are either switching or you are repeating the viral load in 2 months' time, right? So let me see what you are saying on that particular question. Would you switch to second line? Hey, it's a mixed, it's a mixed answer. Okay, at 30 seconds, we can stop and share the results. All right, so I see 66% said no, we won't switch. And that's probably the correct answer, right? Because the first log, this number here is 5.6. After adherence and all interventions, we are now at 3.9. If you take 5.6 and you subtract or minus 3.9, you're gonna get 1.4, 1 point something. But the key thing here is that if you go back to this algorithm, there is more than one log drop, right? Reduction in the logs from 5.6 to 3.9. If there's more than one log drop, we don't switch to second line. We repeat the viral load in 2 months' time, right? So this is very important. Let's look at it as question 6. It's the same question, but the scenario has changed. You are comparing viral load number 1 and viral load number 2. Will you switch to second line or not? That is the question. Can you try again? It's a different scenario. Will you switch to second line? All right. Yay, I wonder how. All right. It's fine. Let's share the results. The logs are giving us a problem, isn't it? So if you had your calculator with you, right, you will take the first log then, which is 5.99, right? If you say 5.99 and you minus 4.43, right, 4.43, it would give you 1.56, 1.56. So going back here, the difference between the logs is more than 1 because it's 1.56. So if it's more than 1, what do? You don't switch to second line. You repeat the viral load in 2 months' time, right? So going back to scenario 2, the correct answer there, because the question is, will you switch the patient to second line ART? Your answer should be no, I won't switch. Why? Because there is more than one log drop between the two viral loads. You know, I'm not very happy with, I hope the next one you get it. Okay, right. Let's look at, it's the same question. Let's try this one. It's a different scenario, but it's the same question. Please look at it very carefully before you select your answer. All right. Can we share the poll again? Yes, can we try again? Looking at these two logs, 5.1 and 4.95, what is your plan? When you subtract these two, if your answer is less than 1, you are getting a 0 point something, you should then switch. If it's 1 point something, you should not switch, you should continue. But let me see. Will you switch? Hey. Aibo. All right, please share the results. I need to get a calculator on my because I don't think we are getting it nicely. So I want to do this practically with you, right? And show you the calculator. So here's my calculator, right? So the first viral load, if I remember very well, was 5.1, right? That is the first viral load, 5.1. And I'm subtracting minus the second viral load, which is 4.95 or something like that. And then I say equal to, you see, so the difference between the two logs is less than 1. 0.15 is less than 1. So there was no improvement between the two logs. If there is no improvement, when we ask you, will you switch to second line, your answer should be yes, right? But I see 23%, you still said no. So the correct answer should have been this time around, yes, we are switching because there is no improvement between the two logs, right? And how do we know? Because the difference between the log for the first viral load and that of the second viral load is less than 1. So I hope you got it this time around. All right, let me go back and then we try again. Will you switch? This is the last scenario. Will you switch to second line ART this time around? The first log is 3.73. The second one is 3.21. All right. Let's reshare. Thank you. Let's try again. All right. At least those who are saying yes as a percentage is quite high, but I think it's okay. I was hoping for 100% this time. Yeah, you can share the results. All right. So yeah, it seems the logs are still an issue, but at a very basic level, you take your first log value, which is 3.7, you subtract your second log value, 3.2. If you get an answer that is equal to 1 or more, you don't switch. You continue and repeat the viral load in 2 months' time. If you get a 0 point something answer, that means the difference is less than 1, the number 1. Therefore, your patient has failed and they need to be switched to a second line regimen. So the correct answer here for question 9 would have been, yes, I will switch to second line. All right. I hope you got it. If you don't get it, please ask again in the chat or something so that we can try and explain it nicely again later on. So in terms of switching, if you have a pregnant mom taking efavirenz, you have confirmed 2 viral loads more than 1,000, there is no log drop, so there is no improvement. Your next regimen should be a dolutegravir based regimen. Unless if there are contraindications due to drug-drug interactions generally, you would then probably opt for a lopinavir, ritonavir, or even atazanavir, ritonavir, PI-based regimen. But our patient is taking efavirenz. If we are switching her to second line, we would then offer her a DTG-based regimen. So here we are from the guidelines. Our patient is taking first line ART regimen. She's taking an NNRTI-based regimen because the regimen has efavirenz, right? So she's taking tenofovir, lamivudine, and efavirenz. If we believe that she has failed, we would check her hepatitis B status. If the Hep B status is negative, we would give her zidovudine, lamivudine, and DTG, right? Hopefully, zidovudine and lamivudine is a fixed dose combination. So the patient will take 1 tablet twice a day plus DTG. So it's 3 tablets per day, right? If hepatitis B is positive, remember that means we have to keep TDF and lamivudine in the regimen to also control for hepatitis B there, right? So we would give tenofovir, zidovudine, lamivudine, and DTG, right? How do you simplify this regimen, right? So you would give TLD. You see now how you use the fixed dose combinations. You would use TLD, 1 tab daily, TLD, plus zidovudine twice a day. So it's again, even if here you are dealing with 1, 2, 3, 4 drugs, but the patient will still take 3 tablets in 24 hours. It will be the TLD as a once daily, and then AZT twice a day. So it's 3 tablets still. So remember what I said about minimizing the number of tablets by using fixed dose combinations as much as possible. All right. So for the mother, just remember to always reinforce maternal adherence, always offer women HIV testing. Don't forget to do your routine monitoring, viral load, creatinine, CD4 count, TB screening. These are the things we'll have to do again, and also look at infant feeding support here. She might need to do a pap smear later on, and also offer family planning, contraception to prevent unplanned future pregnancies, and then do your nutritional assessment. Your last question for today is about the child. So Tebo is now born 4 hours ago. What do you want to do for our baby Tebo there? What do you want to do for Tebo? Tebo is born, is here. So let's do the last question on Tebo. Okay, thank you. Last question on Tebo. Tebo is born from Maria. What would be some of the interventions to do during this visit for Tebo? Yes, we see your hands. Hopefully, if we will be done now. I think I'm targeting that by 1:30 I should be done so that we can have enough time for questions. All right. Yes, let's show the results. I think it's fine. Let's show the results. So, few things about these results, right? This child is high risk. So whenever you hear the word high risk, 2 things must happen all the time. A PCR must be done, and dual infant prophylaxis with zidovudine and AZT. We cannot postpone the PCR testing to 10 weeks because she has to be tested today. The child we need to know today whether the child is positive or not, right? And then nevirapine for 6 weeks would not be enough for this infant. The infant needs nevirapine for at least 12 weeks, zidovudine for 6 weeks, and a PCR must be done. So B and C are probably the best options for this child. Yeah. So again, just to look at the overview in terms of recommendations for PMTCT in infants, 2 critical strategies. Number 1, we quickly need to get the mother to be suppressed. So probably switching her to a better regimen, second line with dolutegravir would be part of the plan. Providing early infant diagnosis. So we want to provide a PCR test for this child today. Once the child tests 6 weeks, just sorry about that, the kids are back. So I was just saying here, early infant diagnosis by a PCR, and then starting quadrimoxazole from 6 weeks. Once the child turns 6 weeks, we can start quadrimoxazole, but then infant post-exposure prophylaxis for a high-risk infant, dual. This is a combination of zidovudine and nevirapine. Nevirapine for 12 weeks and zidovudine for 6 weeks. We always want to promote and protect breastfeeding. We promote it by encouraging mothers to breastfeed. How do we protect breastfeeding? Number 1, we encourage it exclusively. We keep the mother suppressed, and we offer prophylaxis to the infant as long as the mother still has a high viral load. Let's not forget that our HIV exposed infants are high risk babies. Sometimes they are still testing negative, but they are not growing well, they are not developing well, they are not doing well at school, they are stunted, you know. So we want to keep them negative, but we want them to be healthy, growing kids who are able to contribute later, you know, to life and the economy. So I have already summarized this to say, if this was a low risk scenario, we would be giving nevirapine for 6 weeks. But this is a high risk. The mother disappears. We believe she's got a detectable viral load. So we would give nevirapine for 6 weeks, and then nevirapine for 12 weeks together with the zidovudine for 6 weeks, right? So I won't say much about that. Now, I think that's what is confusing people, because the baby is born and then we are thinking we'll do a PCR at 10 weeks, right? Yes, this is the schedule as prescribed. So birth PCR must be done, 10-week PCR must be done, 6 months and 18 months, rapid test, you know, 6 weeks post cessation of breastfeeds, we can do a PCR. Anytime the child is symptomatic, we can do a test. But what I want to say is that anytime you assess the child as a high-risk infant, you should test the child. That test is not included here, but it must be done. Let me give you an example. A mother who had previously been negative throughout her pregnancy, she's been tested, she was negative, she delivered, she was negative, she was tested during the EPI visit, she was negative. At 9 months, when the child is now 9 months and they're coming there for the measles and other things, they test the mother tests positive for the first time during breastfeeding, and the child is 9 months old. On that day, you would assess the mother, prepare the mother for ARVs, start the mother on ARVs. Is the child low risk or high risk? The child is high risk. So what do you do for high risk kids? 2 things all the time, in addition to many other things. PCR, dual ART prophylaxis. So don't forget, as soon as you say high risk, we have to test the child and we have to provide a high risk prophylaxis irrespective of the age of the child, as long as the mother is breastfeeding right there. All right, so I hope you have grasped that situation there. So like I said, your HIV exposed infants, we classify them as high risk. So these are high risk. Even if they are remaining PCR negative, they tend to have poor birth outcomes, they develop slowly, they tend to be admitted, and sometimes they lose their mother. So they should be monitored very closely with their mothers. For the child, again, in addition to the PCR that you are going to do and the dual prophylaxis, start Quadrimoxazole from 6 weeks, continue it for as long as the child is being breastfed. Make sure that you monitor growth, development, and nutritional status. Encourage breastfeeding exclusively for the first 6 months. Ensure that all PCR results are checked and we track them. If they're positive, we start the child on ARVs as soon as yesterday. Ensure that immunizations are always up to date. And I can tell you, if we do these things, we might win with our program, right? So if a mother presents with a high viral load, switching drugs doesn't help, doesn't improve adherence, right? So the first thing is to improve adherence. Check the results of your viral load, act early on high viral loads. If the viral load is very high, consider a complete regimen change. Don't do a single drug substitution when the viral load is high. And then a single drug switch only do if the viral load is less than 50 copies. All right. And then I know it's a beautiful picture, but there's a message. The message here is that if someone brings a child and the child is sick, right? That we are bringing in a child because the child is sick, always ask about the mother. Where is the mother? Is she well? Is she okay? Because the child might not do well unless we take care of the mother. The opposite applies. A mother comes in, she's sick, she tests positive or whatever issues she has, we should always ask about the children. How many children, how old are they? Are they healthy? Have they been tested? So see the mother, ask about the child. See the child, ask about the mother there, you know. So, I mean, in terms of this particular topic, I'm sort of done. I just want to maybe discuss one case, and then maybe I will stop there for today, you know, and there's a reason why, because I've had a lot of calls about mothers who are testing positive after being on PrEP, right? This one, you don't have to, it's just for you to think about it. So here we have Tabile, 24-year-old, test HIV positive after being on PrEP for 6 months. She is 2 weeks pregnant, right? So how do you approach the case? You can type in the chat box, but I'll just tell you a few things at the high level, though there's one bullet I want to emphasize. So number one is that you would assess for opportunistic infection and consider any opportunistic prophylaxis that, like we have said, you would fast track her for initiation, counseling. You'll determine if it's someone who can be started today or you need to wait based on her clinical presentation. You would assess which regimen she's eligible for. And I want to come back to this number 4 because probably that's the only message from this case. And then you'll choose your drugs, take baseline tests, and then monitor and do your follow-up, you know, for your patient. The part I really want to focus on is bullet number 4, right? It's important to note that when we say she has not failed ARVs, she has failed PrEP. What is it? What do I mean by failing PrEP? Remember, PrEP is a prevention program. Patients are taking Truvada, tenofovir with emtricitabine on a daily basis, right? Now she has tested positive. It might be the issue of adherence, adhering poorly, whatever the issue is. But at the end of the day, she is pregnant, right? She is pregnant. And number 2, she has tested positive after being on PrEP, right? The key thing here is the decision to say, what regimen are you going to give her? Are you going to give her TLD? Remember, she has already failed T and L as part of PrEP. Her virus was exposed to these 2 drugs, right? Or are you going to give her ALD, zidovudine, lamivudine, and dolutegravir? And remember, though there's now good research to show that dolutegravir might do well, even under the context of a weak NRTI backbone. Now I'm talking something else, but just remember that dolutegravir, in terms of our South African guidelines, we want to prescribe it with at least 1 active NRTI. If you give this patient TLD, you cannot assure us that she has an active NRTI because she has just tested positive whilst taking these 2 drugs. Please don't forget that particular piece there, right? If you give her ALD, which is zidovudine, you are giving dolutegravir and you are protecting dolutegravir by giving an active NRTI right there. That's why resistance testing is recommended for all patients who test positive after being on PrEP for more than 6 months, right? It is in our guidelines. And let me see if I can show you some of on the guidelines. Just give me a few seconds. Yes, I have resistance testing. There we go. So I'm just sharing from the guidelines so that you can see it nicely. So this is from our ART guidelines, resistance testing, indications for resistance testing in adults and adolescents, right? That last bullet here is what we are discussing today, to say any newly diagnosed client who has received PrEP in the last 6 months must receive what? A resistance test. And that's exactly why I wanted to discuss this particular case with you, to say if you have, remember now there's a recommendation that HIV negative pregnant moms must get PrEP. You know, some of them will be adherent, some of them won't be adherent. We had 2 cases last month of failed PrEP patients one pregnant, the other one not pregnant, and you have to do a resistance test. If it comes back sensitive, you can give TLD. If it comes back resistant to tenofovir, then ALD is the best option. We don't want to predispose dolutegravir to treatment failure in that context. All right, I hope you understand that. It was just at the high level. It was just few cases I had in case we had some time. I see it's past, so maybe let me pause there and then maybe hand over. I'm not sure if I showed you. Sorry about that. Let me stop there. So what I wanted to show you was just this part to say, in the approach for Tabile, I would rather do a resistance test. Because she's pregnant, I'm in a hurry to give her ARVs, I would give her ALD. If the test comes back sensitive, then I can give her TLD at that point in time, right? But starting her on TLD is not a good idea if we are not sure that tenofovir, the tenofovir piece there is still an active NRTI. All right. I want to stop here and maybe take your comments and questions so that we have enough time. We can always come back and deal with pregnant women who are failing second line and third line, and then we take it from there. All right, I want to stop there. Thank you, Wenzel.
It's Wenzel. Thank you, Dr. Lesego. Very interesting talk. I learned a lot. And looking by the comments, everybody has enjoyed the presentation as well. So far, we have 3 questions or 2 questions, and I think the third question's already been answered, but I'm going to ask you anyway for your input. The first question is from Sister Obi. At what time can ARV be discontinued by an HIV person based on CD4 counts?
Discontinued. All right. Yeah. So what I want to say, and ARVs, yeah, okay, I think now I understand the questions. Yeah, so a few things. Number one is that when we start ARVs in pregnancy, right, we are starting these ARVs for life. There was a time in the early days where we used to start, women would only take ARVs during the pregnancy period. And after delivery, we would then stop ARVs. Then we had a lot of issues. Number one is that if you stop ARVs for someone who was previously suppressed, they have what we call a rebound hyperviremia. So viral loads would shoot very high, CD4 counts drop significantly. These women would present with severe opportunistic infections, septicemia after delivery. Some of them, even died. And also from a public health point of view, we couldn't even trace some of them back into care when they now needed the care, because the monitoring at that time for patients who are not on ARVs was quite poor. So what we used to call structured treatment interruptions is not something that we recommend. I do know that there are new studies now looking into that issue again to say if a patient started with a high CD4 count and they've been adherent and they are fully suppressed, can we consider a treatment break, and so on. This is just at the study level, but at the program level and at the clinical level, once you start ARVs are started for life. We are not going to interrupt ARVs based on CD4 count. And actually, if you interrupt, you might be destroying, the treatment future for your patient, because they might end up now with stage 4 conditions, which could have been prevented. So I think that is the risk, to say to stop or not to stop. But at the program level, at the guideline level in South Africa, once you start on ARVs, you are on ARVs for life at this point in time. Thanks.